The American College of Emergency Physicians has long been our greatest advocate for providing the highest quality of care to patients presenting to emergency departments across the U.S. In its ongoing commitment to all emergency patients, ACEP is pursuing initiatives that can help rural EDs gain parity with their urban counterparts. Today, we are going to talk about some of those advocacy efforts with ACEP President Dr. Aisha Terry and with the new VP of Communications, Dr. Ryan Stanton. Let's join that discussion now. Welcome to this podcast on the topic of onboarding in emergency medicine. We have some very special guests today. Happy to invite the American College of Emergency Physician representatives today. We have our president of ACEP, Aisha Terry. Dr. Aisha Terry, hello. Thank you for joining us.
Hey there, Steve. How are you?
Very good. Thank you. And we have Dr. Ryan Stanton, who I first met as liaison to the rural section of ACEP when I was chair-elect and then chair. Went through a lot of learning during that time and how policies work at ACEP. And Ryan has a new role as VP of Communications and board member, getting to be long-term board member by this time. So,
yeah, getting a little bit long of the tooth here, but yeah, we did learn a lot together. When you were the new chair and I was the new board member for ACEP, you learn trial by fire quite quickly when you're trying to figure out how the processes work.
Yeah, and talk about trial by fire. Aisha, you really stepped into a storm in ACEP with APP going bankrupt and leaving ACEP members in the lurch. In addition to everything else that ACEP is trying to keep in the front, ahead of us and on the front burner. But I'm sure priorities change as a leader in ACEP, just like they do in the emergency department as you see new patients come in, right?
100%. You know, you never know what the topic of the day is going to be for your presidential year. It's just completely unpredictable. And so it's fine to have an agenda, but just know that that agenda needs to be flexible. And so we kind of take it as it comes, just like we do in the emergency department.
Right. So on that topic, tell me about, let's, for our audience, just let them know what ACEP is, why was it created, and what's the role and what are our priorities?
Sure. So ACEP, or the American College of Emergency Physicians, was created in 1968. Actually by 8 physicians out of Lansing, Michigan. That's the home of ACEP. And essentially, even then, the goal in terms of creating this organization was to provide training and standardized training for physicians to care for patients in the emergency department. And even then, it was about quality, Steve. It was about making sure that patients receive the quality care they deserve in our emergency departments across the nation. Of course, emergency medicine is a relatively young specialty. And so, 1968 wasn't that long ago, certainly relative to other specialties in the House of Medicine. So we've certainly come a long way, but we have not veered for a moment away from that original principle that resulted in its creation. And that is that patients in emergency departments across the country receive quality care from trained physicians.
Right. So go ahead, Ryan.
And it's one of those things that initially we started off as filling a gap in the system. Where do our acute care patients go? My dad was a vascular surgeon, and there used to be the space in the hospital where your patients would show up and you would go down and see them. That became the emergency room. And so, the first 50 years of ACEP is about building a specialty. And now it really is about advancing a specialty and truly treating it as a specialty, because I think that's what we've learned over the years, is that it really does take a special knowledge and education and skill set to be the highest quality emergency physician. And so, we're in this very interesting time right now. We're in this transition from what is a traditional specialty that's almost got locked doors in terms of, neurosurgeons get to do neurosurgery. And so, you know, this weird transition, this challenge that you and I have felt, and you and I have dealt with the rural side of it, where we're in this interesting transition where most of our city centers are very much board certified emergency physician centric. But then there's other settings around the country that are still critical access in areas where hopefully we have access to moving forward and can provide board certified services to them.
Right. Well, and on that topic, ACEP has made huge strides in putting emergency medicine trained and boarded physicians in emergency departments across the country, but preferentially and predictably in those high volume facilities where we've trained and really made that the standard. And that is who these health systems look for at high volume facilities. We're still working our way to those rural hospitals, and that's been the challenge. Traditionally, the local family physician was in charge of those small communities and would, you know, have their clinic and oversee the emergency department, and then other physicians on staff would fill in, whether you're ophthalmology or OB or cardiology, you know, you had to do your turn in the ER. Now we're seeing people specialize in emergency medicine, and we've made those strides in, you know, over half the emergency departments in the country. And now we're struggling with that other portion, a large portion of EDs representing a much smaller volume of patients because they're a smaller volume, but still working our way in that direction.
Yep, absolutely. We know that, you know, again, ACEP being, you know, a relatively young organization and a relatively young specialty, we have seen, you know, really the transition from our forefathers and women who started the specialty to now solely understanding that the specialized care that board certified emergency physicians provide is a necessity, that is essential. ACEP also certainly recognizes limitations that we have. The reality is that, you know, we have a maldistribution of emergency physicians in this country. Today, I wouldn't say that we have a shortage actually of emergency physicians, which is not the case for some specialties, but we certainly have a maldistribution. And unfortunately, what that results in is, you know, there being a lack of equity in terms of care that rural patients receive relative to having access to a board certified emergency physician. So then what do we do about it, right? It is a reality for many. As you mentioned, there are several hospitals and emergency departments that see very low volumes of patients, but yet those patients certainly still require and need life-saving care. You know, the beautiful thing about emergency medicine and what makes it really unique is that we see undifferentiated, unscheduled patients, right? And so our patients just show up. They don't have to have an appointment, and we don't know what we're going to get. And so when you're taking care of a patient with that degree of complexity, it really is important that you have the adequate training necessary to provide the care needed, and it has to be done quickly.
And the simple fact is people tend to stay where they train. And we have this concentration of education programs like your Nat sound you're hearing behind me right now. I'm in New York City at a mass gathering conference. So we got a little NPR feel here. But, you know, it's the whole idea that people tend to stay within a radius of where they train. And so that's one of our big goals is how do we get folks more exposure and interest in rural and critical access settings. And at the same time, you know, that skill set that we talked about very early is that it is a special skill set because you're doing so much more in these rural settings because now you are every physician. And so we as ACEP have the goal that every single patient in the United States has access to a board certified emergency physicians. But the reality is that transition point that we're in right now, where we continue to hope to see those numbers grow and advance the access in areas because we feel every patient, no matter where you choose to live, should have access to the best and brightest.
Right. Rural is a pretty diverse set of hospitals. In Massachusetts, rural might be a 30 or 40,000 volume ED where you actually could support emergency medicine trained and boarded physicians. As you get to the Midwest, some of our volumes, we call them frontier critical access hospitals that have 4,500 or 5,000 visits or less. We have some that are less than 2,500, some less than 1,000. So that trickle down to that type of volume may just not be reachable. And ACEP has produced a policy and guideline recently on APP supervision that speaks to exactly what we're talking about. And ACEP also collaborated with the American Academy of Family Practice to have this discussion as well, that preferentially we want physicians in these low volume EDs, but acknowledge that as the volume gets lower, there needs to be other supervision, and at least by tele-emergency medicine. Can you speak to that a bit, Aisha?
Yeah, absolutely. It's interesting because I just got back from the AMA interim meeting in National Harbor in Maryland. And there we had many discussions with all of our colleagues, including AAFP, around rural practice and how we have to look at it as a granular situation and issue, that it's not a one size fits all. You go to one small rural emergency department and you've been to one small rural emergency department. For example, even looking at Nebraska, for example, compared to Indiana, I mean, I think traditionally, we think of both of those states as being pretty rural states overall, but the fact is there are vast differences even between those two states relative to volume of patients in emergency departments. And so what ACEP has certainly concluded is that the gold standard for the provision of emergency care is certainly done by a board certified emergency physician. And we also recognize that emergency medicine is absolutely, a team sport. Without a doubt, I cannot do my job as an emergency physician without my entire team, which certainly includes nurses and technicians and NPs as well as PAs. So ACEP is very much in tune with the fact that this is a team sport, and in emergency medicine, we rely on every single team member and they're all integral. We do say, though, that team should be led by a physician. We think that in terms of having that team work cohesively and safely in order to provide the best quality care to patients, that there does need to be supervision of nurse practitioners as well as PAs by a board certified emergency physician is ideal, certainly. We do, however, in our policy recognize the fact that if we're dealing with a rural emergency hospital, REH, or a critical access hospital, that in those instances, while we do insist that there is real-time access to a physician, that can be done via means such as telehealth.
Mm-hmm. Yeah, and on the topic of rural emergency hospitals, you kind of touched on a moment. We had ACEP was tasked with writing response to CMS on conditions of participation. And as we did that, we looked at the current conditions of participation for critical access hospitals. And interestingly, when you look at, okay, these hospitals need to have the proper equipment. So it had, all your airway stuff, it had IVs, resuscitative equipment, all the way down to the urinary catheter. I use that as an example because it's that specific. And then the second condition has to do with training of the providers that work there. And it says that you can be a physician, you can be a PA or NP, that they will acknowledge that, they will reimburse that. And then the second thing is, so they have to have their license. The second thing is they have to be emergency medicine trained, and that's where it stops. And it doesn't give any elaboration on the physician, PA or NP, what their training needs to be. And there are facilities that have just, decided that, well, I guess, our standard in the past was ACLS, ATLS, and PALS when they were family physicians. And that was perhaps the resuscitative side for that acute population that would come in that they may not have had as much training in as family physicians. And maybe that was the gap that needed to be filled. There's a much larger gap to be filled when you graduate from a PA or NP program. And AAENP and SEMPA both recognize that and need some guidance as to what that gap needs to be. And then in addition, recognizing that we need to have an emergency medicine trained and boarded physician as medical director in these emergency departments and be able to oversee that care and assure that there's proper telemedicine support. So we were going to write a condition of participation for these rural emergency hospitals that's greater than what it is for current critical access hospitals, but that would set such a higher bar for these rural emergency hospitals that these small hospitals wouldn't convert to rural emergency hospitals then. So it would be an impediment to it. So it was really a difficult thing to try and write and advocate for. But we weren't asked to rewrite the criteria for critical access hospitals. So it just, I mean, it kind of elucidates the complexity of this as you try and solve one problem, another one emerges.
Yeah, indeed, it's definitely complex. I will say that it's nice to be at the table with CMS, right? And so, you know, you mentioned about, you know, the advocacy that ACEP and other organizations, AAFP, continue to pursue through our federal agencies, such as CMS, to ensure that we have the guidelines and the criteria and the legislation and the regulatory language that we need in order to practice as safely as we can in providing quality emergency care. It is tricky and it is complex, and it goes even deeper than that, Steve, as you know. I mean, even when it comes to billing practices, much of that is dependent upon the insurer that you're talking about. So, for example, Medicare and Medicaid have very specific criteria relative to even billing when you're talking about, you know, seeing a patient that may be what we refer to as split services, where it's being provided by a physician as well as perhaps an NP or a PA, and who can bill for what, and what percentage of the time must that individual who bills actually see the patient physically. And so it does get complicated quickly, and it really behooves us to, again, continue to do the strong work that ACEP and others are doing in terms of advocating for our specialty through really influential groups like CMS.
And I think that's one of the big things in consideration. And thanks for a little bit of gap there. We just missed the lunch rush for 5 minutes where we got to about 100 decibels in here. So, you know, hopefully more reasonable for everybody. But, you know, it's very complex. And that's the challenge with leadership. That's the challenge with being the major organization for emergency medicine, is nothing lives in isolation. Nothing lives in a vacuum. There's so many players, and even the slightest change in one approach may have significant impacts. Let's use, for example, payer parity with regard to telehealth. If we fight for that to be equal, then it's not bringing up telehealth, it's bringing down the rest. What are the downstream impacts? The negative impacts are going to impact larger populations, larger groups, and the specialty as a whole. You know, and so we as ACEP have our gold standard to say our goal is to have every patient have access to a board certified emergency physician. Understanding the realities. I would love for every person in this country to have access to a commercial aircraft, to be able to fly where they want to go. Delaware, our first state, doesn't have a commercial airport. You look at Uber or Lyft or those rideshare services that started off in big cities and has now started to percolate down to smaller and smaller communities, but there's still significant portions of the country that don't have access to rideshare or transportation services. You know, we are just like that in emergency medicine, where as we grow, we start to space out. And so it's how do we bring all these pieces together to understand what the gold standard of goals are, with the fact we are part of the healthcare team and the resources. And as Aisha mentioned earlier, this is not a physician in isolation. It's PAs, NPs, nurses, techs, environmental services, physical plant, whatever it may be, all of this stuff coming together to say, how do we provide the best possible access for every patient out there? And it's just a simple fact that, you know, 2,500 patients per year to pay off the cost of a new physician who's coming out, who's got $500,000 in loans, it may not be practical. But here, as we move forward and we now have the full breadth of physician age groups within emergency medicine, we now have everything from new to post-retirees, that we have that opportunity to say, you know what, once I'm done with Baptist Health, 50,000 patients and strokes and heart attacks and substance issues and things like that, maybe for me it is worth going and hanging out and working at 2,500 just with my years of expertise that I have and being able to use that as my transition. So, that's things we look for. What are our opportunities? How do we improve access and improve the quality? Because we would not be a specialty if it weren't for family practice. We wouldn't have what we have if it weren't for those physicians and other specialties that were willing to step in and do the job and to really establish it. We wouldn't have the access we did if we didn't have, especially in years past, with our non-physician practitioners. But as these transitions happen, it really is about saying what is best for the patient and how do we make that happen realistically in the environment that we're working right now, and understanding that a little change may have big changes elsewhere.
Absolutely. And I think you're absolutely right, Ryan. There's a huge opportunity now. And I'd argue now more than ever. I recall actually chairing an ACEP membership task force many, many years ago, I think in like 2008 or so, 2009. And we were having the same issues then as we're having now. Ryan, you mentioned Uber and Lyft and how it kind of percolates down eventually. I will say that in terms of our shortage of the provision of rural emergency care by boarded emergency physicians, we really haven't moved the needle too much. But we do find ourselves, I think, with new opportunities. I think in the post-COVID world, we're seeing changes in terms of staffing models and the like. We're seeing changes in terms of staffing shortages, certainly in particular relative to our nursing colleagues and the like. And so there's really an opportunity to take a step back and look again at how we can solve this problem, because it really does boil down to an equity issue. I think that many years ago, we often wondered, why is emergency medicine not included in many of the federal pieces of legislation around loan repayment that would then encourage emergency physicians to go back and practice in rural settings. And a lot of other specialties have access primarily to primary care specialties and the like. And emergency medicine, it's kind of like we straddle that fence. Are we outpatient? Are we inpatient? We're certainly not really primary care, but we do a lot of primary care. And I think because of that, we've actually not been included in a lot of those pieces of legislation in terms of loan repayment. I think now's the time to take another look at it and see if the timing of where we are relative to being post-pandemic and all that we've learned over the past few years might serve us well, to see if we can go back and see if that might be a solution in terms of really upping the ante relative to loan repayment for emergency physicians to work in rural practice.
And those are good long-term solutions, and we've looked at some of those. And then we recognize that with a lot of the expansion of emergency medicine residency spots over a period of 10 years, Bennett and Camargo, Carlos really laid that out pretty clearly, that now you've saturated your urban settings. And are you really going to push those physicians to that rural practice? And how low of a volume is that even sustainable financially? And I get that this is a great long-term plan, and having more emergency medicine trained boarded physicians in rural is the ideal, and we're working toward that. But in the meantime, if a rural hospital or a health system that has rural facilities wanted to get recommendations on how to and who should work in those emergency departments, does ACEP have an answer for them, or an onboarding kind of process? Who should be there, and what recommendation would you give for a frontier critical access hospital? That's a tough question, I know.
Yeah, it's a tough question, but we have been thinking about it a lot for a long time. And certainly what ACEP would say is that emergency care, no matter the zip code, should be led by a board certified emergency physician, and that emergency departments should be staffed preferably by a medical director who is also an emergency physician. And so we're very clear about that. We also emphasize that having, non-physicians help us care for patients is important and vital. And in no way do, we feel that, to just remove all NPs and PAs is not the solution by any means. We are a team sport for sure. We do again have some carve outs in our language in terms of our policy that absolutely acknowledges limitations. We are pushing to really, advance our access to technology and use more and more telehealth again to make sure that there is access in real time to every single patient in the country to an emergency physician. And certainly to a physician, if not a board certified emergency physician. And so that's what the answers would be, to rely on, technology. I think that also we have to begin to start at home in terms of really identifying, if you will, hometown heroes. People who are from rural settings and beginning the pipeline early in terms of enticing them and promoting them and recruiting them into the specialty of emergency medicine. I think that those efforts just have to be deliberate and sustained. And again, I think that starting far upstream in terms of the pipeline, so starting with, kids in high school, it wouldn't be an immediate, we wouldn't immediately see the fruits of those efforts, but certainly I think that we would long term.
And I completely agree. We can't move the needle unless we set the needle. And so our goal, our standard should always be a little bit forward of where we are. Because if not, if we are satisfied with the status quo, we stay where we were 50 years ago or prior to that. And so for these to say, yes, we want you to have this, we would love for this to happen, but we also understand realities. I mean, that's part of my role of VPC for ACEP, is that the challenge of threading the needle with a narrative where there is a very vocal overall minority, a small group of people, but very vocal, that any education of a non-physician is considered the opportunity to replace or taking a job from a physician. And in no way, shape, form, or fashion does ACEP ever believe that a non-physician practitioner should replace a physician role, no matter what type of physician role, especially for any economic strategy or financial strategy. It should go the other way. If there is a need, if there's a requirement, if there's the setting where an NPP is necessary, then at what point, volume or acuity wise, does that transition to a physician-based role? And so it should continue to move that needle, but also understanding the realities of these settings, of saying, unfortunately, what we did is we walled off. When I talked about locked doors before, we locked the doors on our education before we locked the doors on the actual practice. And so we can't send our trainees to a place that has non-boarded emergency physicians. And so working with ACGME, ABIM, all of these involved, understanding this, the workforce study is the best way to get people into rural settings and interested in rural settings, is get them exposure to rural settings. And many of us come from rural settings. I live in central Kentucky, about 20 miles outside of Lexington, that's on farmland. And I've lived these rural settings, a lot of these things. So I understand. But a lot of folks, that's not the case, and they don't have that exposure. So addressing to say, okay, if we have an opportunity or if we have a gap, how do we actually fill that gap? And then the challenge with ACEP is also threading the needle with the narratives of the challenges with the workforce study, with the realities of the practice of medicine in the United States, of the access. So there are some that would legitimately say they would rather for patients not to have access than to have access to somebody who's not a board certified emergency physician. And I think the reality is for all of us, especially us that are in rural settings, is I want you to have access first. And then how can we figure out how to have better access and more access? and that when you live in Hazard, Kentucky, you have the same quality and care and opportunities that Manhattan, Bronx, places that are just epicenters of large hospital systems are going to have as well. And so that's the challenge that we have, is when we have these ideas, we have these discussions. Now let's see how we're going to work this in terms of the response, the landing spots, the who is it impacting? To say that we only, absolutely, the only qualified emergency physician is a board certified emergency, ABIM boarded, ABOM boarded. That turns our back on our legacy physicians, on our family practice physicians, those that have dedicated their lives to emergency medicine. And so, for us, that big tent of saying we're family, and let's continue to look through the windshield of the car, because there's more ahead of us than there is behind us, and we can't change anything that's already happened. All we can change is today and what we want to do in the future, and then working together to figure out how to get that best plan for our patients.
Yeah, I absolutely love that analogy that you just made, Ryan, in terms of the rear view mirror and in the car and we're driving along. I love that. It's perfect.
I'm an NASCAR doc. That's what I do.
Exactly. You mentioned about how it's really important to be aspirational and to look ahead, right, in terms of the future, in terms of achieving goals. And, I'm here in DC where I do a lot of health policy work, particularly at the federal level. And I can tell you that policy and guidelines and legislation, the whole point of it is to inspire us to aspire to a better version of what we're doing, to have some goals in mind. And so, I personally think that there's nothing wrong with having aspirational policies, really, that push us to seek the best and highest quality that we can. The other beautiful thing about policies, though, is that there are carve outs. And so, if you've ever seen a legislative bill, it's really thick. It's a lot of pages, right? And so there's a lot in there, which includes, some granular details around carve outs for special circumstances, recognizing that it's not a one size fits all. I also just want to emphasize that, this is about quality. It's not about, okay, we want to have all board certified emergency physicians just for the sake of having board certified emergency physicians. We know for a fact that training matters. We know that experience and number of hours spent training certainly impacts your ability to provide quality care. The typical emergency physician spends about 16,000 hours of residency training hours compared to much fewer, on the order of maybe 2,000 or so residency, or not even residency, but clinical training hours for some of our NPs as well as PAs. And so that is the difference. Like, that's what makes a physician different, is really the training and the experience, the hours and hours of seeing case after case after case. And so that is a fact. We also know that there's increasing data that is showing that when care is provided by a non-emergency physician in emergency care, that, the outcomes are impacted in terms of patient outcomes. And so that shouldn't be ignored either. We know that when it comes to readmissions, as well as costs, one recent study actually found that those indices tend to be higher in terms of readmissions as well as costs when there's not a physician in the mix in terms of caring for emergency patients. And so I think it's really important to acknowledge, that there is increasing data around the quality piece, and also that, ACEP is very much engaged when it comes to quality emergency care. I'd say about 12% of ACEP's approximate 160 full-time staff members are devoted to our quality portfolio. And so there are pieces like EQUAL, which is the Emergency Quality Network, that really allows for all emergency departments in rural settings and otherwise to participate in virtual learning around specific areas of quality to ensure that we can do all we can to make sure that patients are receiving quality access to care through training and the like. And one more thing to just mention is that ACEP has a new accreditation program for emergency medicine. And one of the key things about our accreditation program is that we recognize that we want to raise all boats. Okay, it's very important that we don't leave anyone behind. And so while in the accreditation program, we certainly speak to the importance of having a board certified emergency physician on site. We also recognize that there are other tiers, and we want tiers of achievement, and we want to give everyone an opportunity to, again, aspire to achieve the highest level of care.
And Steve, you talked about, and we talked about a lot, and also I can throw it back to you, kind of turn the interview table. But a lot of the challenges we had is if there's a gap, that gap will be filled. And your big concern when you were chair of the rural section was that these gaps were being filled by folks that are straight out of school, no practical experience, being thrown into independent settings. And the challenge is when we take a stand back, hands off approach, that's what fills the gap. And so now I have patients that are being seen by an NP or PA, but an NP usually, who has zero clinical experience and now has zero clinical oversight, that they don't have a structure in place. And so we, as the American College of Emergency Physicians, as emergency physicians, we have to be involved with that to understand, is this ideal? No. But is it going to happen? Yes. So how do we make sure that this patient doesn't suffer undue harm or inferior care because I'm afraid for my job? Doing the whole South Park, they're taking our jobs. And so we have to be willing to be involved to say, here's what we want to see, but understand these realities of saying there has to be some sort of baseline education because this is a specialty. You don't just walk into it. That's not fair. It undermines all of us. If we're saying this level or this lack of information, education, training, experience is okay in this setting, but not in this setting. It wouldn't happen in my setting. You have to have at least 2 years of experience before you can come into my setting. And so, that's why we have to be involved. We have to be intimately involved, understanding that there's going to be a fair amount of resistance, but there has to be standards and training and oversight. I think COVID, as much as it sucked, gave us great opportunity to see, one, it throttled telehealth, giving great opportunities to see how that we can fill gaps and make care happen in times when it's difficult. So telehealth as an opportunity, some of the remote supervision, if we can't have it on site. But we as ACEP have a couple of things. We have our gold standard that the best care is going to be from specialty trained emergency physicians, but understanding that it's going to be challenging, but that completely against independent practice of non-physician practitioners, there has to be physician-based oversight and ideally emergency physician-based oversight, as Asia alluded to and mentioned, the medical director being a board certified emergency physician to even help with all of that. Now, again, there's going to be caveats. There's going to be areas where it can't completely happen that way. But let's use that as the opportunity rather than saying we're going to turn our back on that population of human beings because it doesn't meet to exactly what we want to see in every single facility. Give them the best possible care we can give them now. And then what do we do moving forward to make it even better for them, to move that needle even further? Because you don't go 0 to 60 by skipping 2 through 59. You run through all the other numbers first, and then you get to 60. And that's what we're trying to do with a lot of these rural and critical access settings.
Right. Well, you guys both raise terrific points, and we know where we're headed long term. Where I've seen the rub is with traditional or our physicians that are my age and and older, who went through that battle early on in establishing emergency medicine as a specialty. And that wound is still open, that they had to fight some battles to really establish emergency medicine. For those that have lived it and have worked alongside PAs and NPs more, and see the modern realities, as I talk with EMRA representatives and the young physicians, they want to practice in a large volume facility like they trained in, but at the same time, they have a real interest in helping rurally. And we have the ability to indulge both of those interests through tele-emergency medicine. And that's very appealing to many of them, to still be able to work. And there are facilities that have that model, such as Avera, where all their physicians work at a large volume trauma center, but then spend time doing tele-emergency medicine to support these emergency departments, that it's not likely in our lifetimes that we're going to see emergency physicians getting to a 2,500 volume ED in South Dakota or Wyoming, that sort of thing. But they have the ability to impact the care of those patients 7 or 8 hospitals at a time. The Mayo system does the same thing with their outreach, and they have specific criteria for those PAs or NPs to work there, but they aren't working in an independent status, so to speak, even though politically that may be available for them in half the United States. Another point I wanted to make as well is both SEMPA and AAENP are on the same page as what we're all talking about with emergency medicine physician supervision, and with having some guardrails up in working at some of these facilities. And I think that there's a way to kind of bring this all together, getting past the political side of it. How do we collaborate and take care of this, very low volume? Because that's really the elephant in the room. We can talk about rural generically and moving emergency physicians to lower and lower volume. But again, the trickle down to the very low volume is going to be a long, long road. And in the meantime, there are patients every day that are seen by inexperienced or no experienced PAs and NPs, and some family physicians too. There should be a level of training that's required, and coming together politically, as you mentioned, Asia, as well, with CMS. They certainly would rather have ACEP go with AAFP together and collaborate and get a lot more people nodding along. But imagine if we went with AAFP, SEMPA, and AAENP and said, no, we need to have more specific requirements under training for critical access hospitals to even work in these. Just saying they need to be EM trained and then leave it up to the credentials committee at that hospital to say, oh, you just need ACLS, ATLS, and PALS, you're good to go. Because we found that was the threshold for the vast majority of these small hospitals. And that's just not obviously emergency medicine training.
Yeah, no, I really appreciate those comments, Steve, because just in Philadelphia at ACEP 23, we met with the leadership of SEMPA. We also meet routinely with the leadership of our emergency nurse practitioners, and you're absolutely right. The reality is that we're actually on the same page when it comes to independent practice of PAs and NPs and how we don't agree with it. I think we need to shout that from the rooftops to really kind of squash a lot of the myths associated with some of the politics on this topic. And you're absolutely right. We need to figure out how to collaborate and come together. We had discussions in Philadelphia actually about some ways that we can collaborate in a way that's visible and in a way that moves the needle from an advocacy perspective. And so I really like what you're saying in terms of even having all of us meet with CMS and to collectively come up with some solutions that work.
Right. And with this, I think it's important to stress too, Steve, when you mention these programs with telehealth, there's always the respondents that are going to be glass half full, glass half empty. There's going to be those that's my goal and what we see as ACEP as a current status quo plus. How can we add services? How can we add access? Those that are potentially detractors may say, we're just going to use this as an opportunity to cut physicians, to say we don't want physicians there, we'll never have physicians there, to actually cut access to physicians. And for us, it's just the opposite, to say this gives us the opportunity to increase the access to physicians, and eventually, once the volume, acuity, is there of being able to insert those physicians in those environments when it can be sustained and financially viable long term. Just understanding payer mixes, volumes, reimbursement, hospital settings, whatever it may be. But I think that's an important part to drive home is when we're talking about telehealth access, we're talking about an addition to the current existing status. And then as we move forward, continuing to grow, moving forward, eventually towards those gold standards as those physician populations and specialty populations continue to grow and folks realize the greatness of being able to see the sunrises and the sunsets and play outdoors and have horses and cows and things of that nature that really are what it's the greatest part of being a human being.
Yeah, well, I very much appreciated my time on the rural section as chair. It was great to see the inner workings of ACEP and how you advocate for rural patients and all. And it was fun to be part of that process of trying to move the needle. And it's encouraging to see that needle is still moving under this leadership. Really appreciate your coming here, Aisha, today and talking about this issue. And Ryan, thanks so much. Great to connect again. But you guys have the foresight and hopefully we can keep this needle moving and still continue to improve care for our rural patients and collaborating with all of our providers that work in those facilities, physician and non-physician.
Steve, I appreciate you inviting us in. I once again apologize for the fact that we learned trial by fire together and accidentally, more than anything else, stepping into the octagon when we made a mistake and taking our punches.
I appreciate you having my back on that. It was it was helpful to learn that way. And
sounds like I wasn't there, but it sounds like I don't know if I want to know the details of what you guys are talking about.
Nothing terrible, all good intention, but it's amazing how feathers can get ruffled with the best of intentions. So and you can imagine talking about issues like we're talking today, how it can potentially ruffle feathers. So
just
imagine. We're a passionate group, that's for sure.
And Aisha, just as a teaser, just think about the conversations we have in the boardroom between accept and approve. And that really boils down to what this conversation is about.
Yes. Or file.
Yes, that was it. That's exactly it. The file. Yeah, that's what Steve and I learned about very quickly, and not in the most congratulations, strong work kind of way.
Yeah, absolutely.
Again, always with the best intentions. So
of course.
Yeah.
Well, thanks so much for the invitation, Steve. This has been great. I hope it's been helpful. I mean, the fact is 15% of emergency patients are in rural America. And so this is absolutely in our lane. It will continue to be, and just really excited about, again, having huge opportunities, I think now more than ever, to expand even how we think about the practice of emergency care. Just really quickly, just to mention, ACEP put together a task force to look at alternative ways of practicing emergency medicine. We know that a lot of docs are looking for something different outside of the traditional brick and mortar of the ED. And I think now's the time to push things like telehealth, to push things like more novel ways and creative ways to take care of all patients.
Right. No, well said. So, well, thank you again. And we'll hopefully get to have another conversation at some point when we move that needle even further. So thank you, guys.
Absolutely. Thanks so much. Take care.